Hello everyone. Thank you for this opportunity. My name is Uchechukwu Ahanonu, and I'm presenting on a research work which was titled "Silent Threats and Missed Opportunities: Rethinking Pediatric TB and HIV Co-infection in the Era of Universal Test and Treats (UTT." So I'll be going with the word UTT just in case. Over the last decade, global rollout of Universal Test and Treat (UTT) has significantly expanded ART access for children and adolescents living with HIV and AIDS. Um, Over the years, with the HIV infection, not necessarily us, but scientists have been able to come up with the ART, and so far so good. It has been of immense help in treating, not like treating, but managing HIV case over the years. But yet, we've still found out that pediatric TB continues to fly under the radar, often undiagnosed until it's too late. Also, symptom-based screening has failed in pediatric population, leaving many undiagnosed. The children living with HIV and AIDS are immunologically vulnerable, and adolescents fall through the cracks of the system, meaning that they are at risk due to care transition gap. So moving from infancy to adolescent has brought in a gap for adolescent kids ranging from let's say 10 to 18 years. Here is a map of so our program was mainly focused on conducted a progressive cohort on from 2021 to 2024 in these four regions: South Africa, Kenya, Malawi, and Nigeria. And in total, we enrolled a total of 1,138 children ages from 18 to 30, 0 to 18 living with HIV and AIDS over the period of 24 months. Yeah. And then in order to carry out this research, we stuck with combination of methods ranging from symptom screening based on WHO guidelines, chest X-ray for those with symptoms or clinical suspicion, gene expert MTP, RIFF, ultraspartum and gastric sample, and notably the stool-based testing. This is sorry I skipped this. This is a map of regions we use with places like sub-Saharan having high impact of HIV and AIDS as it goes by. Um, our major objectives in this research work was to evaluate TB, the diagnostic patterns in children and adolescents living with HIV and AIDS, to assess TB preventive system treatments coverage, to analyze clinical and immunological profile linked to TB outcome, and to identify missed opportunities and delays in TB diagnosis. Also, we also have them to highlight vulnerabilities in adolescents in this our work. Our major goal is to understand where breakdown occurs despite existing policies and technologies. Talking about our study design, this is our focus: Malawi, Nigeria, and Kenya, with a number of 1,038 children enrolled in the system. The key message here was to children and adolescents living with HIV and AIDS face serious risks of developing TB, and in many cases are being missed currently in screening method. The key points here are high TB rates despite HIV and HIV care. Out of 1,038 children enrolled in this research work, 198, which is like 19%, develop active TB. Nearly 1 in 5 of them, even with the access to HIV treatments, TB remains a major threat. Symptom checks mix many cases. Talking about 38% of TB cases have no symptoms during the screening, because most of them we are trying to look at kids, and then relying based on symptoms, we're not able to get results because most of them are asymptomatic. Two stool tests helped find more TB. The stool tests helped find about 23% of more TB than the sputum. Then drug resistance in teens. Drug resistance in teens contributed 11% of TB cases were resistant to ramifeslin, a key TB drug, mostly in adolescents. Due to the intake of this drug, it's helped prevent the identification of TB in adolescents, making it hard to detect. And early diagnosis is very key. So when it's hard to detect, you find out that kids live years without being detected and becomes a problem. This is worrying because teens often struggle with treatment and need target support. This is a chart. We need we need better child-friendly TB screening tools beyond just symptoms and more attention to adolescents at risk of TB resistance. And this is a scalable solution. This is a chart. And then the charts, this is what it shows. Symptom-based screening detected 54% of TB cases. Sputum-based testing captured 23%. Stool-based diagnosis contributed 23% as well. This virtual use clearly supports the key points. Stool-based testing plays a critical role in improving TB diagnosis among children and adolescents dealing with HIV. Talking about missed opportunities, misdiagnosis and mortality rates. This is a chart we have. Um, Trying to explain this chart. Here's the chart titled "Missed Mortality by Timing TB Diagnosis in Children Living with HIV and AIDS." The chart is illustrating early diagnosis was associated with 3% mortality. Talking about if talking about this, it's trying to explain that with the advent of early diagnosis, we were able to um get a 3% mortality rate. Missed or delayed diagnosis led to significantly high 11% mortality rates. We had higher number of people dying because of missed or delayed diagnosis. This stark contrast underscored the key message: early TB detection saves lives, and delays, even in the ART era, can be fatal. We should avoid delay, and early diagnosis helps to save life. A call burst highlights um, clinical predictors of TB. Here we focused on unsuppressed viral loads of greater than 1,000 copies, the CD4 count of less than 500, and odd ratio at 2.4, 95% CI 1.7 to 3.3. This slide is ideal for reinforcing the message that delayed diagnosis is deadly and risk is measurable and preventable. Key takeaway for this research is um, symptom-based TB screening missed too many symptom-based TB screening misses too many pediatric cases. Most missed or delayed TB diagnosis occur in children who were asymptomatic because we were thinking they could express themselves, but we found out that they're being asymptomatic, and reliance on symptoms alone is no longer justifiable, especially in high-risk HIV population. Stool-based diagnostics are effective and feasible in low-resource settings. This talks about the tool we use identify 23% of otherwise missed cases, knowing that they are ideal for children who can't produce sputum. They are non-invasive, scalable, and unutilized. Adolescents face by greater risk but the least support. So in this just emphasizes the need that adolescents, due to the transition period, they are taught to be able to express themselves, but we found out that due to drug resistance in their system, we found out that TB was dictated late. You know, yeah, lowest TPT uptake of 29%, highest rate of ampicillin resistance, and weak engagement due to care transition and stigma. The stigma faced by all these kids also contributed to the fact. Viral suppression and immune recovery are protective but not guaranteed. Even among viral suppressed kids, those who are taking the medication and have reduced viral loads, TB risk remains, especially in areas with high community TB burden. Prevention and early detection must remain a priority, regardless of the ART status. Moving forward, these are the key recommendations. So integrate tool-based diagnostics into routine pediatrics TB screening, especially for children who can't produce pattern. Scale up adolescent-friendly TB HIV service model, tailored to care for teens, improve cases, and try to create trust and adherence. The stigma in HIV is, as much as yes, is reducing, but it's still there. So trying to get a system that is friendly, where trust can be created, and is going to help in trying to detect TB early. Also, leveraging on digital tools. This is the era of social media. Trying to get some apps, games, and SMS reminders will help boost the TBT completion. Also, strengthen data systems to identify high-risk children early. Early flags allow faster diagnosis and care coordination. We must move beyond waiting for symptoms. Early child-friendly tools and smart systems can help catch TB before it turns deadly. I want to acknowledge my friends and colleagues who, in one way or the other, have contributed to this research, talking about Dr. Stanley, Dr. Ade, and also the international HIV and pediatrics and HIV community for giving us this opportunity to present in this conference. Thank you very much.